All right, welcome back to the podcast. I am joined today with Dr. Matt Bernstein. He is a psychiatrist in, let's see, multiple roles at this point, but you were mostly private practice for most of your career.
Actually, I started off as an inpatient doctor at McLean Hospital on the schizophrenia and bipolar inpatient unit for about 8 years. And I've always, throughout my career, taken care of people with serious illness. It's a real passion of mine.
Okay. So you did inpatient for 8 years, then you went outpatient
I work at this
psychiatry.
program that is a team-based approach with people with complex illness called Ellenhorn, and I'm the chief medical officer there. And I also have a private practice. And I also now have opened a program called Accord, which is focused on metabolic treatments for mental health.
Okay. So conflicts of interest, we were talking about this. Is it a conflict of interest that you're part of Metabolic Mind as an advisory board? I think I want to mention that. I think you've been given that position because you are bringing patients into ketosis in your practice and you have some expertise on this. But you're not like there's no drug companies, there's no supplements that you sell. You don't have any, um, you know, other than your private practice and your roles there.
That's right. And
You're
Metabolic Mind is a nonprofit focused on education around metabolic and mental health.
okay.
Yeah.
Yeah. And so today we're going to be talking about the ketogenic diet. It's going to be kind of an update. I had Chris Palmer on here a couple years ago when his book came out. And there have been quite a bunch of studies since then. And I wanted to go through each one of those with my audience. I also wanted to kind of pull from you just the practical things that you've learned. You've been putting people into ketosis for a little over 3 years, you said,
Right.
as kind of part of the practice of what you do with severe mental illness, with bipolar, with schizophrenia, and with other types of mental illness as well.
Correct. Yeah.
Okay. And so, and just to give my audience kind of like an idea from what I learned from you, is when you started 3 years ago, you were doing this really by yourself. You would put people in intermittent fasting. You would see if they responded positively that, and then maybe move them to ketosis later on. And then in the last year, you've started this kind of um, inpatient setting, not traditionally like what we would consider like a partial program, but people come, they learn they get into ketosis. Is that correct?
Yes. Well, just to clarify a little bit, when I was doing it in private practice, I would often combine intermittent fasting with MCT oil, which is medium chain triglyceride oil. It's a derivative of coconut oil, and it's extremely ketogenic as a fat. So people may have heard of this drink called a bulletproof coffee, where they put
Right.
butter and MCT oil in it, or heavy cream and MCT oil actually tastes a little better. Um, so if someone's fasted overnight for 12 hours and they have one of those drinks in the morning with the MCT oil and the fat, but nothing else,
Mm-hmm.
and then they can, wait another 4 or 5 hours before they have their first meal, they often can get some ketones just from doing that one
Mm.
intervention. Not high levels, but a little bit of ketone, a little bit of ketosis, maybe a BHB, beta hydroxybutyrate level of, let's say, zero point 0.3 or zero point 0.5. But that's enough for a lot of people to feel a difference in many ways. They often feel some cognitive clarity, some extra energy. They don't feel hungry. And so that's a little taste of sort of what ketosis might start feeling like for them. And many people try that and love it and feel energized. And they say, well, they come back to me and say, well, what was that? That was amazing. That wasn't just like coffee. That was super
Mm.
amazing. And then they're really open to learning more about this whole science and potentially going further in their metabolic therapy.
I first got introduced to the ketogenic diet actually through I was at a conference giving a talk on psychogenic seizures.
Mm,
I was running a program for people with psychosomatic issues, and so I was at this neurology conference, and it was put on by some ketogenic foundation, and I was like, "What is this? Like,
mm.
is this really being used for people with seizures? Like, how does that work?" Um, and so, tell me like a little bit of that history, just to kind of prime us for this idea.
Sure. Yeah, I mean, we can go back really far in history to, pre-agriculture times, and we can go back to Hippocrates, where they were using fasting to treat seizures in 5th century BC.
Mm.
But of course, fasting is not a very sustainable treatment, to maintain ketosis. I mean, eventually you have to eat, and you'll break your ketosis unless you're eating ketogenic. So that didn't really get figured out until 1921. A doctor at the Mayo Clinic published a small case series of some kids that he put into a what he called a starvation mimicking diet or a ketogenic diet. They knew about ketones at that point, and he figured out how to create a diet where the body will make high levels of ketones. And he reversed epilepsy in 3 kids, I think it was. And then published that and published the theory behind it, and then it really took off. People started publishing rapidly in the 1920s about using ketogenic diets to treat seizures. And that literature just kept growing, where eventually there's now 12 randomized controlled trials showing that ketogenic diets work in both kids and adults with epilepsy. And it not only works, it works with people who are drug resistant. So that's really important point, because some of these kids and adults are on, 3 different seizure medications at a time. They've tried, 8 or 10 of them. They still can't get control. And then the ketogenic diet can still work in those really treatment refractory situations, in a good percentage of the time.
Yeah, I'm curious, what level of the beta hydroxybutyrate are they getting to get into a place where it's actually helpful for their seizures?
Well, interestingly, the literature is pretty old, and people weren't measuring beta hydroxybutyrate levels daily through most of
Mm.
these trials. Often they're measuring it, once a week or even less. And so we don't even know in the epilepsy literature that well
Mm.
how high of a level of BHB you need to get most of the time. They more measure it based on the ratio of the diets. That was usually the sort of how they measure the intervention. So in a ketogenic diet, we think of a ratio. The classic one, when in 1921, was a 4-to-1 ratio of calories from fat compared to calories from protein and carbohydrates combined.
Four to
And
one.
yeah, almost no one does a 4-to-1 anymore, ever. I mean, that's like a really, really extreme diet. You're getting, almost 90% of your calories from fat. And you think about
That's
that,
okay.
you're going to be protein deficient on that diet, almost
Mm.
certainly. You're even below probably the RDA, US RDA protein levels, which are too low for most people anyway. And so what they learned also, as they were doing these studies in epilepsy, is that you could reduce the ratio and still get the same benefits in almost everyone. And so they ended up with more like 2-to-1 ratios or even 1.5-to-1 ratios. There was even a study that was really interesting at the Mass General Epilepsy Clinic. They had people on a waiting list to get into the ketogenic diet
Hmm.
program, and they put them on, just on their own, the families, they just told them eat this low glycemic index diet, which is really more liberal, much more liberal than even like a 1-to-1 diet, but it's all the carbs are from whole foods. And they're still low carbohydrate. You're not eating anything that's going to raise your blood sugar rapidly. Um, and those kids did almost as well as the kids on ketogenic therapy.
Mm.
And they weren't able to correlate it with the beta hydroxybutyrate levels. So, and we'll get to this in one of the studies. We are really still early in trying to figure out the science of, do people really need a BHB level in a high range? And when I say a high range, I mean above 2 or 2.5. That's really deep ketosis for someone. But could people get some of the same benefits, at least a subset of people at a much lower BHB level? We don't really know all the answers to that yet.
Yeah, that's good. This is good practical information because as we're thinking about our patients with mental health, we want to monitor like compliance. I know compliance is to some degree related to the success of if this is going to be successful. Um,
And
okay.
interestingly, it's a treatment where we actually can measure the level of the treatment much better than with most medication therapies. So I can see if someone's, their BHB level. I like to check them daily for people, especially in the first few months, and we really can see, is the treatment causing this biomarker to change that I want to change, as opposed to, if I prescribe any antidepressant and most antipsychotics and mood stabilizers, I can't know even what the level of the treatment is in their blood, whereas in this I can, which is cool.
Okay, so let's talk a little bit about the bidirectional relationship between metabolic issues and brain disorders.
Yeah.
And I almost recognize, like, because I'm so much on Twitter and there's so much anti-psychiatry there, there's this kind of sense that, schizophrenia isn't even a brain disease, depression isn't even a brain disease. So so we're going even further than that and saying, actually, no, and metabolic stuff influences this to a high degree. Tell me about the bidirectional relationship here.
Yeah. Yeah. Well, of course, these are brain diseases. I mean, that I think, is without a doubt. There's so much data, but what we are saying though is that, the mind and the body are intricately connected, and that the brain is influenced by the metabolism of what's going on all throughout the body and the metabolism in the brain itself. Um, there's multiple studies. I think the one that I really find interesting is this one. It's Perry from JAMA Psychiatry. I think it's 2021,
Mm-hmm.
and they measured kids longitudinally. So this not only was showing a bidirectional relationship, but showing a before and after a little bit. So these kids, they were measuring their metabolic health and mental health, and they followed them for a lot of years. And the kids with the worst metabolic health in childhood had much higher risk of severe mental illness when they got into their 20s. And so they looked at something, and I think the data showed that the highest quartile of insulin levels at age 9 compared to the lowest levels of insulin at age 9, there was a threefold increased risk of schizophrenia in their
Mm.
20s. So, I mean, that's a really big change just from insulin levels. And we know from other studies that insulin resistance is involved in all these mental illnesses, including schizophrenia.
Yeah, that doesn't surprise me. It it kind of makes me think about how there's a lot of data on increased rates of schizophrenia in lower SES groups. And I think about how lower SES groups often um, just just by the nature of what's available uh, are kind of consuming more highly processed foods, increasing insulin, increasing metabolic disease, and maybe that's a big part of it. Probably there's also just increased risk of different types of traumas, neglect, that kind of stuff as well. Um, but okay, so this specific study. It's called Longitudinal Trends in Childhood Insulin Levels and Body Mass Index and Association with Risks of Psychosis and Depression in Young Adults.
Yeah, the depression part, I think it was at puberty, the kids who gained the most weight had a fivefold increase risk of major depression in their 20s.
Yeah, these odds ratios are very high.
Yeah,
Um, so this is an adjusted odds ratio of 5 with
yeah,
psychosis and psychotic disorder 3.2. So wow, very high. Puberty onset major increase in BMI was associated with depression odds ratio 4.46,
mm,
but not psychosis.
right,
Um, so people who had gained weight right around puberty, that was more depression.
right.
Okay.
So there's, that's an interesting one because there's, some before and after effects. So, sort of suggestion of causality, certainly not proof, but, some of these other studies look at rates of obesity leading to higher rates of depression. And if you're depressed, you have a higher risk of becoming obese afterwards as well. So that was a separate study. And similar things with diabetes. There's some work by Cynthia Calkin. We'll talk about one of her other papers where she looks at much worse course in bipolar disorder if someone has insulin resistance, prediabetes, or diabetes. They have a much more chronic and tractable course of their bipolar illness as well. So there's a lot of things in the literature about this bidirectional relationship.
Mm. Part of me wonders with that if the medications are part of that difficulty, right? Because let's say someone has more severe mania, they may need higher doses of medication. Those higher doses of medication may naturally come with increased obesity. Um, like if they're on lithium, Zyprexa, you know,
Right.
and they're still not getting better, and then you increase the Zyprexa, and now they're they've gained maybe 20 or 30 pounds in the next 6 months. Um,
Yeah, yeah, you're bringing up a super important point. These medications, I worked on an inpatient unit. I appreciate greatly that these medications are wonderfully important and effective in acute illness, and they save lives. I mean, I've seen medications save lives dozens and dozens of times when people are acutely ill. I've also seen, ECT save lives, and I'm a big believer in medical treatment for severe illness. But what I think I'm coming to is that they're really good in the acute phase, and they may actually impair recovery. They may impair long-term outcomes if we continue to use them at high doses in maintenance. And that's a real concern. And of course, I have many people on maintenance medications, and as
mhm.
I'm a practicing
Yep.
psychopharmacologist. So, but it's really concerning to me that I think the data is now starting to really show us how dangerous they are metabolically and how important metabolism is for long-term outcomes.
Right.
And so, you put this all together, and I think as a field, we have a real problem to contend with.
Yeah. I'm an outpatient psychiatrist too, and I treat people long term, and um, it's kind of like you get them stable. They need to be on the antipsychotics. If
Right.
someone's psychotic and they're stomping the shower because they see spiders and they're screaming, this is a traumatic state to leave them in if we don't treat them. And I think people who are anti-psychiatry who just think, oh, why don't you just use natural means? Why don't you just tell them to exercise? It's like, no, you don't understand severe mental illness if you think you can get someone like that to exercise, period, right?
Right.
You need to get them out of the psychosis. But then once they're stable, it's like, okay, how do I get them to exercise? How do I change their diet? Uh, and then how do I carefully monitor them? There's a lot of nuance there, and like decreasing their meds.
Right.
Some people are super risk averse, and so they never decrease the meds ever.
Right.
I'm a little bit more willing to decrease the meds and then try to catch early on if they're decompensating.
Right.
But not everyone's like that.
Yeah, I mean, I think this is a good opportunity to talk about this paper by Lex Wondering from 2013, if we can go into that now, because it's exactly on this topic. This is now not a new paper. This came out, 2013. It's a group from the Netherlands, but I think it's incredibly important for everyone to know about. This is super influential in my career, treating people with antipsychotics. So they were doing a dose reduction study, and they took all the people who had first break psychosis in their catchment area, and they offered to be in this study about dose reduction and discontinuation of antipsychotics. So they got them stable, first episode psychosis, 6 months of stability to enter the study, and then they put them randomized into two groups. So one was dose reduction, discontinuation, in collaboration between the patient and the doctor. So that's really important. It wasn't just a schedule that was preordained. The doctor and the patient both could input into what the right timing was of dose reductions, and even to stop dose reductions if they wanted to. But their goal was to try to get the dose as low as possible and even towards zero if they could. And the other arm of the study was maintenance treatment, sort of by APA guidelines. A low dose of an antipsychotic, but not trying to reduce the dose towards discontinuation. And they kept him in that randomized setting, or different arms for 18 months, I believe.
Mm.
And in that first 18 months, as we would imagine, there was more relapse in the dose reduction group. Actually, more than double the relapse rates. So, like 43% relapse in that first 18 months versus, I think, 21% relapse. So, if you stop there, you say, why should anyone be reducing medication? This is a bad idea.
Hmm.
But they didn't. They did a follow-up 5 years later. So it was
Mm.
7 years after the first episode, 5 years after they were first in that uh, randomized treatment groups. So essentially, after the 2 years or after the 18 months, let's say, they were allowed to do whatever they wanted. So it's just sort of, go and live out in the wild, basically. You're not in a study anymore. But then they contacted them again 5 years later, and they did this very thorough evaluation on like 80% of the people
Hmm.
that were in the original study. So they ended up studying over 100 people. It was like 103 people at the 7-year mark from their first episode of psychosis. And they had tremendously improved outcomes. So they were measuring this very fancy functional recovery scale, and they were measuring the PANS. Those are their sort of two things that they were evaluating. And both were much better in the dose reduction group at 7 years.
Hmm.
So that was really fascinating. And in the end, they did a Kaplan-Meier plot of relapse rates, and the lines ended up crossing. So you had more relapse in the dose reduction group in those first years, but by about year 3 or 4, they were having fewer relapse rates than the people who were in the maintenance treatment group in the first 18 months. So really, really interesting.
Hmm.
And just to give you, the listeners a little bit of the data, um, because it's really amazing data. So in terms of symptoms on the PAN scale, at the 7-year mark, they were almost the same in terms of symptomatic recovery. About 69% in the dose reduction group, 67% non-significant change in terms of symptomatic remission. But the functional remission was way different. So the dose reduction group at 7 years had a 46% functional remission compared to a 19.6% functional remission in the maintenance group.
Hmm.
And if you add those two things together, symptomatic and functional remission, they had this term called recovery. You had to have both symptomatic remission and functional remission to meet the criteria for what they called true recovery.
Okay.
And true recovery rates in the dose reduction group were 40.4% versus 17.6%. It's a huge difference. The p-value is 0.004. And so, that's an amazing study. It shows that, if we try to reduce doses in those first periods of time, maybe not in the first 6 months, but if you wait for some stability and then, in the next 18 months, you really try to reduce the dose, you're going to get better long-term remission rates.
There's so many questions I have from this. Like one is, are you reducing people with borderline personality disorder? Because sometimes they can present early on with something that looks like psychosis, suicidality. Because we know from other data that those patients don't need to be on antipsychotics, right?
Yes, although, first episode psychosis, I don't think there's too many borderlines lumped together in a first episode psychosis study. I mean, working on an inpatient unit, someone comes in, if they're really psychotic, I mean, they're hearing voices and they're having these sort of first rank Schneiderian psychotic symptoms, thought broadcasting, thought withdrawal. That's not just borderline personality disorder. And so, I do assume that they did a pretty good evaluation. This is a pretty serious academic group that did this study. So yeah, maybe a few slip in, but I don't think that's a big portion of it.
I think that the key takeaway from here is that we may have good reason to be a little bit willing to try the dose reduction
Yeah.
and to monitor, and then to also think about other ways of treating people long term.
Yeah, I agree. I think it's important that the psychiatrists recognize that the patients are often coming in and saying, can I be on a lower dose of this medication? I don't like the way it makes me feel. I'm gaining all this weight. I'm sluggish. I'm tired. I can't think. And the psychiatrist is thinking to themselves often, well, I'm taking a huge risk to lower this dose. We have a risk of some relapse, and that's seen in the study too. Of course, there is that risk, but there's also reward potential in the long term for this person, and that's an important just other side of the ledger for people to have in their minds, that it's not you're not just doing this because someone might feel better in the short term, have fewer side effects. They really have a much better chance of recovering, 5, 7 years later if we try to get their dose down, and there's real science there. And there's been some follow-up studies that have looked at this same question and come up with some similar things, but no one has done the full 7-year study as far as I can tell. That it's really the length of time that mattered, because the relapse rates were so much higher in the first few years. If you just stop there, you just think, this is a terrible idea. And so that was the really important part of this study is how long the follow-up was.
This is good. I think there's been a sense in the psychiatry community that, if someone has schizophrenia, they probably need to be on meds the rest of their life.
Right.
Um, this is not the other extreme where it's like just take them off. This is you have a provider who knows the patient, who's taking educated moments of reduction.
Right.
Um, and so I think that that is part of the study as well that we need to pay attention to. It's not just you're listening to this, you're a patient, and you're like, okay, I'm just going to get off this medication. It's like, well, you're going to find a psychiatrist or a provider who's maybe willing to go down, monitor, in a very sort of mindful way.
Yeah, and there's a whole, art and science to medication reduction as well, which I don't think we have time to go into all of that right now. But, it's important to look at certain things. A couple things I would say is, make sure the person's not using substances if you're thinking about dose reductions. Make sure they've been stable for a period of time. Make sure there's some family support and other eyes on someone, not just your own, to catch things early. And it's really important to catch things early and potentially go back up on the dose, especially if it's getting serious. Although we may tolerate a little bit of symptoms, that's part of the art of this. Is when we first reduce, we might get a little more symptoms, but is it a amount of symptoms that is tolerable and containable without it turning into a full episode? That's sort of the art of it, and how well you know your patient and things like that.
Yeah, that's good. Okay.
Yeah.
So let's talk about patient selection for metabolic interventions.
Yeah.
What are some of the things that jump out at you as like, this is the person that you're thinking about using these things?
I wish I knew a lot of science behind this. It's right now. It's really we're still in the early stages of figuring out who this is going to be best for. So, I mean, the biggest criteria in my mind as a clinician is, can I get them motivated to do it? Because if they
Absolutely.
don't want to do it,
Yep.
we're not going to get anywhere. And so, if someone's willing to listen to me about some of the data and some of the anecdotes and some of the potentials of benefits for them, if they're willing to understand how to do this, are they organized enough to be able to do this at home? Or do they have enough support around them where family and a team that can help them do this? Those end up becoming, those practical things are probably the most important criteria right now. Do they still have symptoms that are bothering them? Do they have a reason? Do they want to be on a lower dose of their medication? Are they having symptoms that are still getting in the way? Are they having side effects that are getting in the way of their full recovery? What's motivating them to do this, to do something different?
Yeah, I think since I've been talking about exercise, diet for a decade with my clients, not everyone's ready for it, right?
Right. Of
But
course.
I slowly talk about it, you know, when they have pain points when they come in, like, hey, can we try instead of changing your med, can we try to address the pain point with exercise or with diet? It's like
Right.
they're not always amenable to it, but sometimes
Absolutely.
they
Yeah.
are.
Sometimes they are. And I think, it's really another thing that I look at and try to use as a motivational point is, do they have another metabolic condition going on that we can also treat with this intervention? And that may be the thing that motivates them the most, actually. And it's okay if my patient's main motivation is to lose the 40 or 50 pounds that they gained on their medications. Even if my main motivation is to improve their symptoms and reduce their side effects and improve their brain health, we can sort of meet in the middle and come up with this and agree on the same plan, even though our motivations might be somewhat different. Sometimes they just say, well, if it's going to help me lose weight, great, I'll do it. And they don't really believe me about the mental health benefits, but then a couple months later, then they believe me.
Yeah.
Yeah.
Yeah. I find myself pulling up some of the studies and just showing them the data, or I'll send them the studies or send them little
Right.
summaries of the studies. Like I had an OCD patient the other day, and I was like, look, in this one case study, that there's this person that had a benefit. We could try this and see,
Yeah.
if it has a benefit. I also agree, side effects. One of the things that people have a lot when they get into outpatient psychiatry is they have side effects, sexual side effects,
Right.
reduced libido on SSRIs on different medications. And so like they may want, they may not care about that when they're in the midst of a suicidal, place, but when they get more stable, they start caring about these kind of things. They start caring about their weight again.
Absolutely. Yeah. Yeah. They start, people, and they realize that their quality of life is not as good as they want it to be, even if their symptoms are better. Um, they don't have the functional recovery that they're hoping for. And that's always what I have my eye on, is not just reduction of symptoms. I mean, so many studies are all just about looking at, you know, um, these scores on these scales, which have to do with symptoms, and that's
Yep.
important. But it's really what matters is, can people live their life in the way that they want to? And often the side effects are really getting in the way of that.
The other thing, I don't know if you felt this, but with patients who are pre-diabetic, they have
Yeah,
metabolic disease. Um, these patients sometimes can be a little bit more motivated, and I tell them like, look, if you get to a point where you need to be on insulin, you will gain 15 pounds in the first couple months. I remember reading those studies where they started people on insulin and they gained weight, and I was like, wait, why are they gaining weight right away? And it's because the insulin is shoving the extra glucose into fat.
that's right.
Like that's what happens when you inject insulin.
Well, and not just insulin. Most diabetes treatments are actually making the disease worse over time. They're reducing glucose, which is great, and reducing some of the secondary effects, but they're ultimately causing more insulin and gaining weight and more insulin resistance, which is essentially furthering the fundamental process of diabetes, which is insulin resistance. And I can't not mention the fact that ketogenic diets reverse type 2 diabetes as well. And that's been shown in multiple long-term studies now. And that's a whole separate topic of how effective ketogenic diets are in these really severe conditions like type 2 diabetes and epilepsy, and yet they are not considered first-line treatments at all in the medical community. I don't want to get on too much of a soapbox, but that's something to really ponder, I think, for people. We have these treatments, dietary treatments, that reverse these really significant diseases, and yet we don't offer them even to people. Most of the public doesn't even know the fact that ketogenic diets reverse type 2 diabetes. Most doctors don't even know that.
Yeah, I was looking into this before it became a thing for psychiatry. I remember I have a couple textbooks that I got on ketogenic diet when I was looking at it. It's like really interesting that it's I think it's hard to get people on it. And so I think we'll
Yes.
eventually get to a part of this talk where it's like, let's talk about the practical side.
It's really going
Um,
against the grain of, or, not to use a pun, but against the grain of how we eat and how we've been taught to eat by our government, and how the medical community, teaches people how to eat. This is really going against the grain. So, yeah, it is. It does feel like a radical thing to do, to go on a diet like this.
let's take some time going through some of the key studies that have come out in the past couple of years
Sure.
on ketogenic diet and mental health. And by the way, if you're listening to this and you're getting lost in the studies and you want to look at it deeper, we are going to have a good handout. We're 24 pages in right now, and so we'll have that on the website psychiatrypodcast.com. Let's start with Calkin et al. 2022.
Yeah. So, really interesting study. They call this the TRIO BD study, treating insulin resistance with metformin as a strategy for treatment-resistant bipolar depression. So they took a group of people with treatment resistance, very well-defined treatment resistance. They had to be failed at least two standard treatments for bipolar depression, at the right doses for the right amount of time. Most of them had been on at least 8 treatments lifetime for their bipolar, and still were stuck in depression pretty chronically. So these are pretty ill people. There were 45 of them, both bipolar 1 and bipolar 2, and all of them also had insulin resistance, measured by this score called the HOMA-IR, which is kind of complicated, but it's an easy blood test to order, and I order it on everyone now.
Hmm.
I think that's a good clinical pearl we can get into later. But
What is the Homo IR?
so it's a fasting insulin and a fasting glucose, and they do a calculation based on a formula, and that tells you essentially how insulin resistant someone is. It's not the best measure of insulin resistance; it's just the easiest one to get. The real best measure of insulin resistance is glucose tolerance test, which is a real bear of a test to order and for anyone to do. So we generally don't do that, and we do this shortcut test called the HOMA IR. So it's just a single blood draw, doesn't cost that much. You can even just get a fasting insulin without the fasting glucose, or you can do the calculation yourself and save a little money. So it's a really important test, I think, because it's essentially that's the root cause of prediabetes. That's the step before prediabetes. Even if someone's hemoglobin A1C is nice and nice and low, 5.1 or 5.2, and you say, great, this person looks metabolically healthy, they still might already be insulin resistant, because that insulin resistance starts sometimes 10, 15 years before the diabetes process. And insulin resistance is highly correlated with brain illness and mental illness. And in this study, we'll see how important it is for bipolar depression. That's the important point about this study. So they randomized these 45 people, 25 on placebo, 20 on metformin, high dose metformin, which people are probably familiar with. It's a diabetes medication that does have some effect on insulin resistance. And so of those 20 who were on metformin, 10 of them converted to being insulin sensitive on the HOMA IR. And then one of the people in the placebo group actually converted to being insulin sensitive. And then they followed these people using the MADRS and other scales as well. The MADRS was the primary outcome at week 14. And they had a really significant difference in the people who converted to being insulin sensitive versus the people who remained insulin resistant in terms of their response on the MADRS and on these other scales like Hamilton Anxiety Scale, the CGI Clinical Global Impression for bipolar, and the GAF scale. All were significantly better in the people who were converted to being insulin sensitive compared to the people who remained insulin resistant.
Wow. Yeah, this is really interesting stuff. And this is just metformin.
Just metformin,
We're
which
not talking about diet. We're not talking about exercise. We're just talking about metformin.
yeah, just metformin. Now, metformin is, I mean, even in the study, you see, is not that powerful at reversing insulin resistance. It only was able to do it in 50% of the people, and they were using high dose metformin, which, as some users probably know, does have some side effects. There's a lot of GI side effects when you get the dose of metformin up to 2,000 a day, which is generally what they were trying to do in the study. Some people stayed on 1,500 a day, but and even at that high dose of metformin, only half of them could convert to being insulin sensitive. But it is something to know for someone who isn't willing to do big dietary changes, but they're willing to take metformin. This is something to consider. Measure their insulin resistance, see if they're insulin resistant. If they are, put them on a high dose of metformin and see if they can convert to being insulin sensitive and see if that improves their bipolar depression. I think this is a really well done study, quadruple blind, placebo controlled. This is a rigorous scientific study. So, this is the kind of thing. It's small, of course, only 45 patients, but I think there's enough there to say, given how safe metformin is, that it's a reasonable thing to try for people who aren't willing to do diet.
Yeah. So, okay, just a couple things to reiterate here. HOMO IR is how they define insulin resistance. And we can order this fasting insulin, fasting glucose, and we can put this in the calculators online. It's like you multiply them times each other and you divide it by 405.
Right. Well, it
They
depends on what units. You have to pay attention to the units that
pay
your
attention
lab
to the
is
units.
giving it
Yeah.
to. Yeah, these are using not the units from the U.S. They're the Canadian units, which are different. And or at Quest Diagnostics and probably the other big labs around, you can just order the HOMA IR and they'll do it for you. And there's actually a little bit of a fancier one that Quest Diagnostics does. They send it to a specialty lab and they use this C protein that's part of insulin as well, and it makes it a little more accurate.
I also think that sometimes ordering a lab like this and showing a patient like, hey, you are insulin resistant.
Right.
Hey, we need to start treating this. We have a target, we have a number.
Yeah.
There's something about that can increase. It's not like we're just talking about diet and exercise, and we're talking about something physiologically going on that we can intervene, especially early before it becomes a bigger issue.
It's an incredibly important point. Yeah, people really believe lab work like something about that feels so real to my body here. I need to fix it. And no matter what we say about diet, because it'll help your mental health, they may not believe it. But when you start seeing the lab work, that really gets people's attention. I found that to be true almost universally.
Yeah. Okay, let's talk about Sethi et al. 2024. This was a 4-month pilot trial involving patients with bipolar disorder and schizophrenia.
Yeah.
Let's go through this one.
So Shabani Sethi has a metabolic psychiatry clinic at Stanford, and this is her pilot trial. It's important to say right off the bat, the rest of the trials we're talking about do not have control groups. So these are uncontrolled trials, and so that's just a caveat we have to put out there.
And I,
Uh,
I think that's the state of where we're at today, which is important that this is just the beginning of the field. But I think it's important to educate my audience on this, despite there not being randomized trials. There's we're maybe a couple years away from randomized trials. I'm guessing if we were to do an update in 2 years, we'll have two or three of them. How many do you think we'll have in 2 or 3 years?
I agree with you. Some, yeah, a few. But there's probably about 5 or 6 big randomized controlled trials going on right now. Some of them will probably take a little longer than 2 years to come out. But they're bigger trials, they're randomized controlled trials, and almost all of them have a really cool basic science component. We're going to get to one of the pilot trials has an MRS component, but all of these ones that are going on now have metabolomics and genomics and MRS or functional MRI. So we're going to see a lot more science coming out in the next couple of years, which I'm incredibly excited about. But yeah, the state of the field, we're very early in terms of the clinical data. I mean, we're really telling a whole story here, about not just the power of these diets, but how important it is to think about reducing medications. How can you reduce medications with something else to take its place? A whole story about having biological markers to look at as psychiatrists when we're doing interventions. But yes, the clinical trial data is in its infancy, and most of it is non-controlled, as we said.
Okay, so in these participants, a large proportion, 76%, were bipolar, 24% some form of schizophrenia. They had a high adherence to ketosis, 80 to 100%, which is really good.
Yep. And just
Um,
to say, this was a 1.5 to 1 diet as well, without patients. So not a
okay.
huge ratio, and they weren't measuring ketones daily; they were measuring them weekly. And they only said adherent was greater than a zero point 0.5 BHB, which is not very high from a clinical perspective. So we're not even talking about getting people into deep ketosis here. We're just talking about kind of a mild ketogenic diet that people could follow.
Good points. Really helpful.
Yeah.
Um, and I think that's helpful because when I'm put patients on this type of diet, what I do nowadays is I have them get like the keto mocho,
Yeah, exactly.
and for $100 they can get a bunch of test strips. They can get a little device. They prick their finger. They don't have to do it every day, but I want to see, are they getting into ketosis? And so this, according to this study, zero point 0.5 would be getting into far enough to get the benefit, which is interesting.
Yeah. Yeah, but people may get more benefit if they get, I see this clinically, they may get more benefit if they get their levels above 1, or with more severe illness like schizophrenia, bipolar, schizoaffective, or severe major depression. I actually try to shoot for above 2 a lot of the time, especially in the beginning, to try to really see um, a robust response, really robust response. Yeah,
And neither of us have any ties to these companies that are
correct.
selling these devices. Just
Yeah,
we're not promoting what we financially are benefiting from here.
right.
It's so interesting because like there's no drug reps for the ketogenic diet, right? Like when
Right.
I started talking about exercise a decade ago, uh, doing podcast episodes on it 6 years ago, articles before that, is like there's no person coming to a psychiatrist's office talking about exercise. But at the biggest psychopharm conference that's out of Nevada, it's one of the big ones.
Hmm.
They spent the whole time talking about lifestyle stuff.
Amazing.
this last year. And I was like, oh my gosh, like the field is changing, and that's really exciting to me because it's like 6 years ago when people thought I was crazy for talking about strength training and, mental health. So we've come a long ways. And okay, but let's get into like what this study actually found.
Yeah. Yeah. So they looked at some different outcomes. The one that I thought was interesting was the CGI, the Clinical Global Impression. The average improvement was 31% on the CGI, which is significant. Um, and there were 33% of people were considered recovered at baseline, up to 75% people recovered based on the CGI at the end. And then really cool thing too was that there was a difference between the adherent group and the semi-adherent group. So the people who followed the diet better and had higher beta hydroxybutyrate levels had a 92% recovery by the end versus only a 50% recovery at the end for the semi-adherent group. So there's a sort of suggestion of a dose response that we're seeing in that. There's also a significant improvement in life satisfaction, 17% improvement, another 17% improvement in the global assessment of functioning, the GAF. These are all highly significant. 19% improvement in sleep, 32% reduction in the BPRS for the people with psychotic disorders, and the metabolic outcomes were really good too. All the people who had metabolic syndrome when they started were taken out of metabolic syndrome. So, I mean, in every one of these studies that we're going to go through, we can talk about mental health outcomes and metabolic outcomes. The metabolic outcomes are really nice in all of these studies, like really strong metabolic improvements.
36% reduction in visceral adiposity, which I
Right.
think is very interesting because that there's a lot of links to visceral adiposity and future issues.
Absolutely. I mean, that's the dangerous kind of fat. That's the fat that's hanging around your organs. Not, subcutaneous fat. There's a lot of people who are metabolically healthy who have a lot of subcutaneous fat. But if
Mhm.
you have visceral fat, by definition, even if you're not overweight at all, you can have a normal BMI, have visceral adiposity, and you are metabolically very unhealthy. We have 30% of people in America have fatty liver disease right now, almost exclusively from metabolic causes. It used to be all from alcohol, 50 years
Mhm.
ago. Now it's
Yep.
all from metabolic issues from food, and that's very dangerous. This is a sign that, you're going to have multiple problems going forward, diabetes and everything that comes from that, heart disease, cerebrovascular disease, all that's going to happen if you have got a lot of visceral adipose tissue.
Yep. Other things I did a big dive on this the other day that can decrease that is vigorous exercise.
Yeah.
Um, but 36% is a lot. It's a lot of reduction. So,
Yeah,
um,
and I see this all the time because I measure visceral adipose tissue at our clinic. We have a machine that measures
okay,
that. It's one of the
cool.
things that we always see benefits, as well as in the home IR. We always see benefits when people are doing ketogenic diet. Yeah.
So just to go back over the number, 32% reduction in psychotic symptoms in the brief psychiatric rating scale.
Yeah.
That's cool.
Yeah. Yeah.
That's cool. That's so this is impressive. And this is only a 4 month pilot trial. This is only 4 months. And you're
That's right.
getting those huge reductions. Okay.
That's right. And yeah, these interventions are meant to be long term. And what I say to people is, with most medications, you're getting most of the benefits in the first couple of months. But that's not true with this. You get benefits accruing month after month after month. The longer someone is doing these changes, like ketogenic diets and exercise, the benefits just keep accruing over time.
Yeah.
A year later, 2 years later, I mean, you know this. You see people keep exercising, they keep getting more and more benefits as they keep
Right.
doing it. Same with
Metabolic health
diet.
is physical health, like
Exactly.
how well your mitochondria are functioning.
Absolutely.
Uh, it relates to how your brain is going to function. I've been
Exactly.
looking at studies on creatine recently in
Yeah.
mental health, and there seems to be a really nice link there as well. It's helping the mitochondria function better.
Yeah.
Um, so, okay, let's go to Dannon et al. 2022.
Yeah. So this one I think is really fascinating. So this is a doctor in Toulouse, France. towards the end of his career learned about ketogenic diets, and then he actually convinced his sister's family, I believe, to put his nephew on a ketogenic diet who had both seizures and autism. And this boy had an incredible response to the ketogenic diet for both seizures and autism, is my understanding. And he was just blown away. And he said, "All right, I want to try this in my inpatient unit." And so he was an inpatient doctor his whole career. He had all these patients who were coming in and out of the hospital, and he offered this intervention to 31 inpatients. Some of them were admitted just to do this intervention. Some were just getting admitted for other reasons. But these are people with chronic, severe, sort of intractable illness, schizoaffective disorder, severe major depression, and bipolar disorder. And he put them on a whole foods ketogenic diet. He added some vitamins, not high doses. I don't think the vitamins were all that significant in this, but he did. That's important to add. This is also a non-controlled trial, but they mentioned in the paper that these individuals could all serve as their own controls to some extent because they had all been admitted to these hospital units before and never had these kinds of outcomes before. But they didn't have measurements of those previous studies, so they just sort of mentioned that as a throwaway. But I think it's interesting. So they measured adherence just by doing urinary ketones, which is not the best way to measure ketones, but you can see them in the urine. They only measured it once during the study. So really, we don't have a good sense of whether people were truly in ketosis or not, but they just measured it based on compliance with the diet, which was done by a dietitian, and it came in like meal boxes that they were just given essentially on the unit. And interestingly enough, they were only on the unit 6 days a week, and in France, they get to go home on Sunday, even if you're an inpatient, and you just go back to the unit on Monday. So they weren't having the diet actually even 7 days a week. And so they said excellent compliance in 39%, good compliance in 43%, fair compliance in 18%. And then they measured rating scales. So the HAM-D, 23 people got that. The MADRS, 21 people got that. The people who had depressive symptoms. And the people with psychotic symptoms, there were 10 of those, had the PANSS done as well. And then they did the CGI on 27 out of 28. Only 28 people completed the study out of the 31. 3 people just couldn't do the diet. And you had to do the diet for only 14 days. Some of them did it for much longer, but 14 days minimum was considered someone who did the diet and had their outcomes measured at the end. And the reductions in these rating scales are like mind-blowing. They're almost, you almost can't believe how well these people did. So the HAM-D went from 25.4 average to 7.7 average. The
which is basically remission. I mean, that's like huge. That's a huge reduction. That's going from depressed to not depressed.
Right. The effect size, they give a Cohen's D for effect size, 3.1 on the HAM-D. I mean, it's just like mind-blowingly big.
It's ridiculous.
Yeah. Right. The MADRS, similar, even better, 29.7 to 10.1. The Cohen's D was 3.6. And then in the PANSS, 91.4 to 49.3. Huge reduction in psychosis. The Cohen's D was 3.5. And then in the CGI, clinical global impression, 4.9 to 2.0. Now that's also enormous, 3.8. Now, of course, that's a rater scale. That's not a self-report scale. So, there's all kinds of ways this study can be criticized from a scientific point of view. There could be bias in many different directions. However,
sure, patient selection.
Yeah,
these are the patients who are willing to do it. So they're like healthy enough to choose to do it, right?
Trusting of their doctor to go through this.
Right. The belief of the doctor could have a huge impact. But he's been treating them, it sounded like, for years.
Yeah, most of them have been under his care for more than 10 years.
Right.
Some of them longer than that. Yeah.
So it's like, this isn't a randomized trial. I'm not buying the self-randomization type thing. Yeah. But at the same time, for me, it's like I look at this and I'm like, hey, okay, this is a big impact. We should pay attention to this. This is really interesting.
Yeah, and some of the other things about the study were interesting. So 64% were just discharged on less medication than they came in. Only one person out of all of this was on more medication than they came in. The rest were either had their meds changed and it was somewhat equivalent. So, most people were on less medication despite these incredible improvements. So that's really incredible, and great metabolic health improvements as well. All super significant improvements in weight, fasting blood glucose, hemoglobin A1C, blood pressure, liver function tests, total cholesterol. Even the LDL went down, which we don't always see with ketogenic diets. That's a whole separate topic we could get into. But triglycerides went down very significantly, which we always see in ketogenic diets. And most people said it was well tolerated. They did a little follow up, and 46% were still having good adherence in the follow up. 18% were having partial adherence, and 21% had totally stopped doing the diet when they followed them up later. Because it's much harder to do it at home, especially if you didn't get a bunch of education on how to do it at home, and you just were, given this. It's not people need education to learn how to do this. So yeah, huge improvements in metabolic health, and generally, people were interested in keeping doing it when they left. And I agree with you that even though it's not controlled, even though there's all kinds of scientific criticisms of this study, which are valid, it's still really impressive to see those kinds of numbers. I worked on an inpatient unit. I almost never, ever, ever saw those kinds of improvements in an inpatient stay.
Mm-hmm.
Unless it was, some kind of acute manic episode that resolved with the meds, or major depressive episode that someone got ECT and they had that kind of improvement. But otherwise, you don't see those kinds of improvements.
Mm.
And these are not the kind of illnesses that are super placebo responsive, I would say. Like, we don't even do placebo trials in schizophrenia. These are not mild to moderate depression where placebo makes a big difference. These are different kinds of illnesses than that.
Hmm. Yeah, the other interesting things to me in this study was the systolic blood pressure decreased from 134 to 123. So that's like 10 points,
Yeah,
11 points.
yeah.
Triglycerides dropped from 204 to 137. I tend to see, triglycerides tend to increase with more carbohydrates. So that makes sense to me.
Yeah.
Weight dropped about 10 pounds. So there's multiple ways to think about, like, as you talk to patients about this, to get them to think about trying this, right? I've heard from some people this fear of LDLs increasing. So it's interesting that LDLs dropped 10 points in this study. And we also know that there's a difference in types of LDL,
Right.
which you could probably speak to.
Yes. Yeah.
Um,
Yeah. The LDL topic is very complex and it's very controversial. I mean, you could do a whole episode on low carbohydrate diets and LDL, but just the summary points that I think about is, overall cardiac risk goes down on ketogenic diets. That's been seen in big trials. If someone's LDL is high to start, it often stays the same or goes down. Especially if it's someone who's overweight and they're losing weight on the ketogenic diet, LDL tends to go down. Where you see the LDLs going up are usually in leaner, fitter people whose LDL is starting at a low point, and then you put them on a ketogenic diet, the LDLs sometimes do go up. But still, the overall cardiac risk, even when the LDL goes up, the overall cardiac risk goes down
mhm.
because there's so many other factors that go into cardiac risk calculators: blood pressure, triglycerides, HDL, total cholesterol, all these, insulin resistance, all those are very important factors. So even when LDL isolated goes up, overall cardiac risk goes down. There are this subgroup of people called lean mass hyperresponders, where the LDL goes really, really high, and the triglycerides go really low, and the HDL goes really high. That's this triad called lean, which constitutes a lean mass hyperresponder. But they've even done studies on that. These people in ketogenic diets whose LDL are on average like astronomically high, like 300, 350. Some of them are even 500 in the study that they did, and they had absolutely clean cardiac angiograms compared to a control group that had the same profile except their LDL was lower and they weren't on a ketogenic diet. The people who had these super high LDLs had a suggestion of actually less cardiovascular disease on the gold standard test, the cardiac angiogram. So that's a study of about 100 people. That
Right.
that literature is still coming out and really interesting, but it's really changing this whole story about LDL being so important to cardiac risk. LDL, different subtypes, they're really delivery molecules for energy in many ways too. They're not just atherogenic molecules, and some of them are atherogenic and some of them are not. And so if we just measure LDL and that's all we care about, we're missing a huge part of the story.
Right. And things like visceral adiposity,
Right,
things like triglycerides, things like inflammation, right?
right.
That have other impacts. Plus, I mean, if you're in a for people with mental health issues, there's an inflammatory state often associated with acute illness. So if you're able to get someone out of psychosis,
Yeah,
that's going to decrease cortisol, that's going to decrease stress hormones, all sorts of stuff. Like imagine being paranoid and psychotic, getting you out of that state
right.
is very good for the brain long term.
Absolutely. Oh yeah, for the brain and the body. I mean, inflammation we know is correlated with
Yeah.
cardiovascular events too.
Okay. So this is a really good study. Um, Anything else you want to talk about on this one before we move on?
No, I think we can move on. Yeah.
Okay. Let's go to Calabrese et al. 2024.
Oh, I actually
You
I
want to
didn't
skip this one?
I didn't take notes on that one. I mean, that's a small sort of case series, but I think the main point on that one is that, people getting into remission, a few people, just, complete remission. And that's the kind of there's lots of case reports coming out now. Calabrese, there's another couple of ones by Nicole Laurent, who's a psychologist in Washington State with both depression, and she had two people with schizoaffective disorder put in complete remission. I mean, literally CGI is down to zero
Hmm.
and off of medications. And so, there's those types of case reports and anecdotes and stories that are now getting published, and many of them online. I mean, there's dozens and dozens of people who are being put into remission, coming off of all their medications just by being on ketogenic diet, exercise, and
Yeah.
fascinating. Yeah,
The thing I found interesting about this one was it's only three adults, right?
right.
But OCD symptoms improved and binge eating disorder symptoms improved as well. Let's go to Campbell et al. 2025. This is probably one of the most interesting to me.
Yeah, this one's really cool. So Ian Campbell is a researcher at University of Edinburgh. He's very public about the fact that he got into this because he has bipolar disorder and went on a ketogenic diet himself to lose weight and realized totally by happenstance that it completely stabilized his bipolar disorder. And then he got super fascinated in it, and he's a PhD researcher, really really wonderful guy. And so he has a whole group now at the University of Edinburgh. There is this whole group that they're doing lots of studies. This is they came out initially with a clinical study in 2023. This is the same clinical study, but now they're reporting in 2025 on some more outcome measures that are really interesting. And this is all people with bipolar disorder. So
Well, and once again, this is a pilot study. This is
yeah,
not a randomized trial.
correct.
6 to 8 weeks. Interestingly, he describes them as euthymic bipolar patients.
Right,
So it's not like they're acutely ill, acutely
right,
manic.
right.
But the thing that I like about this one is how he looks at the brain, what's going on in the
Yes,
brain, and
right.
so go ahead. I won't take away your thunder. I want to hear it from you.
Yeah, I mean he's a real scientist. So yeah, he's got this MRS component to this study and also some other really cool aspects. So let's get into it. Yeah. So 27 were recruited, 26 began the study, 20 of them completed the study. They had to be euthymic for 3 months. They excluded people with severe hyperlipidemia. They were all assigned a dietitian. They were put on also not an extreme form of the diet, but it was a real ketogenic diet, 60 to 75% of the calories from fat, 5 to 7% from carbohydrates, and the remainder from protein. They did measure ketones daily in this one and blood glucose daily, which is really important because they ended up doing these ecological momentary assessments. So essentially, they were texting people and asking them some questions every day, and they made correlations between their ketone numbers and their responses to these
Hmm.
questions that ended up becoming super interesting. They had a dietitian that met with them weekly and was able to adjust the diet to achieve ketosis and weight loss if desired. So this is also really important. Instead of just being given this program and just
Right.
sort of let go, they had some really nice dietitian support for these people, and they were able to adjust to make sure that they were getting into ketosis and
Mm-hmm.
measuring it daily. The moods remain euthymic throughout the study, except for one person who had a little bit of hypomania that resolved quickly. And we do see that sometimes with bipolar people who go into ketosis. There is sometimes a little bit of hypomania and a little bit of insomnia that you have to pay attention to as a clinician. If someone's thinking about using these things clinically, that's a really important clinical point. And they did see it in this study. So on these ecological momentary assessments, or EMAs, these daily reports, they only had that on a subset of 14 people because I think their technology wasn't working in the first part of the study and they finally got it working. So it was sort of the last 14 people that they were able to do it for. So they had really nice positive correlations between mood and ketones, positive mood. The p value was less than 0.001 on the, and there's nice little plots on the study if people want to look at these. They're nice to look at. Positive correlation between energy and ketones, also p less than 0.001. Negative correlations for impulsivity and ketones, and that actually had the biggest effect size of them all. They had the best reduction in impulsivity with correlation with ketones of all these measures that they did, and also a reduction in anxiety and ketones. All of these less than 0.001. They did not have a correlation between racing thoughts and ketones. That ended up becoming, that was not significant of a
Now
correlation.
the R values for these, point 0.2, point 0.3 for impulsivity, negative point 0.3 for impulsivity,
Yeah,
negative point 0.2 for anxiety. These aren't huge. These are
yeah.
not huge. This is not like groundbreaking. Is it groundbreaking for you? I mean, I like,
I just like to see these correlations, like anything with
okay.
dose response, it's exciting. Yeah, I mean, it's not groundbreaking, but of course, these are also people who are starting off and remaining euthymic. These are not symptomatic individuals.
But I
Uh,
think what you're emphasizing here is that they're they're looking at um like a spot of like this is one day and this
right,
is their ketone level.
right,
And as their ketones are higher, their symptoms are all what we would want them to be.
exactly, right.
That's probably the most interesting thing from
That
those numbers.
exactly. That's what's interesting about it. Exactly. That there's this, yeah, correlation between the levels of the treatment and the nice things we want to see. And so if someone's not feeling as well, we can say, all right, let's try to get those ketone numbers a little higher. I think that's what this says to me. And you'll probably feel a little better. Um, so that's nice, and it's just so nice to have a relevant biomarker in psychiatry. I mean, we do psychiatric treatments all the time, and unlike the rest of medicine, we don't have biomarkers to follow that
Yep.
are really relevant, and it's really cool to have one that seems to have some relevance.
Here's the other thing, and I'm going to just pull up actually the study here for those of you who are watching this on YouTube, so you can see this actual thing, and you can pull this study up at home. But when I look at data, I look at, does the data represent a linear line or not?
Yeah,
Okay, because often there's a step. Like once we get to a certain point, we see a huge reduction. And so I actually think if I were this researcher, or if I, what I would say is like, it seems like there's a step in some of these things. And what I mean by that is when you get past, for example, 3 or 2.5 for the ketones, all
yeah,
of a sudden there's a drop in impulsivity, and there's like a huge drop. Okay.
yeah,
Do you see that?
yeah,
Or
exactly.
for thoughts and for anxiety, when you get past the 2.5 mark, it seems like there's a drop in anxiety, a drop in yeah, specifically anxiety. There's a drop. Do you see what I'm talking about here? Where it's like all of a sudden, boom, it's like every number is low.
Yes,
Um, and so I think as well, when we think about a small correlation of like a point 0.3 or a point 0.2, we miss the overall picture unless we look at one of these nice plots where we see like, no, there's maybe the data is not best modeled in a linear line. Maybe it's best modeled in like a stepwise approach.
right.
And so um, that was one of my takeaways.
Yeah, I really appreciate you doing that. And it's also, to think about that in the context of this being such a short study too. And I was making that point earlier that getting the higher levels of ketones in the earlier stages is probably really important. And we see these really nice improvements when you get above like 2.5 or 3. And I see that clinically all the time. If someone really gets
Yeah.
into deep ketosis, they're like, wow, this really feels amazing. That doesn't mean they have to stay in deep ketosis, at month 8 or month 24. It may be that they don't have to. We see this in the epilepsy literature in the kids that most of them who respond early, they're able to stop the diet after a few years, and their illness not only doesn't come back, it keeps getting better later on.
Stabilize the brain. So yeah, I had a close friend whose kid was in had sort of like intractable seizures, and I convinced him to get their kid on a ketogenic diet, and they did it for a couple of years, and they've kind of moved away more into like I think more a lot of whole foods,
Right.
but not as ketogenic, and the kid's doing a lot better.
Yeah, amazing.
And yeah, so it makes sense to me that if you can stabilize the brain from having seizures for a period of time, and you have a kid that's growing up now, every year it's like their brain is growing up, their brain is developing, their brain is changing,
Right.
and so all these epigenetic things, all these new pathways.
If we reverse that's the cerebral insulin resistance as well,
Right.
then we don't have to do that heavy lifting in the beginning. We're doing this heavy lifting of reversing insulin resistance, getting the mitochondria to be healthy again. And at a certain point, you have enough healthy mitochondria, you may be able to add to that, but the
Mm.
biggest changes may happen in the first 6 months, a year, but you still continue to get benefits as you keep going with a healthy lifestyle, and some amount of ketones are providing that signaling to the mitochondria on an ongoing basis.
That's great. So there's this one study that I really like. Uh, I'll share with you. I don't think you've probably seen this one, but they looked at three groups of people. They looked at people who are more elite level athletes. They looked at people who are average people, and they looked at people who are have some sort of metabolic dysfunction. And they looked at the amount of watts that they could produce
Hmm.
on a bike for a
Yep.
given level of lactic acid.
Right.
And then they looked at the mitochondrial health in these three different groups. And what they found was that yeah, there's a big difference in the mitochondria health. Let me see if I can pull this study up. I want to show you. It's really cool. Yeah, essentially, like my takeaway was if I can improve the mitochondria health of people, it's by Gino San Milan.
Oh yeah,
Show
yeah,
you
yeah,
this picture.
yeah. He's a
Um,
big exercise researcher. Yeah,
Let me just show you this
exercise
here.
physiology.
So yeah, you could see in these different groups of people, the lactic acid, the amount of watts they produce at
Right.
different levels. And so I think this was the most interesting one right here. The relationship between blood lactic acid and exercise output and the three different groups. The the people with metabolic issues, the normal people, and the athletic people. And so it's another picture of this like you know mitochondrial health, the ability to produce watts at different, more watts at lower lactic acid threshold, right,
Right.
is mitochondrial health. And I think
Exactly.
it's kind of feeding into this whole holistic picture that we're giving of how that then can make an impact on our mental health in multiple
Absolutely.
domains.
Yeah, absolutely. Yeah, and if for those of your listeners who heard Chris Palmer before or have read his book, you know all about mitochondria having all these other important functions besides making energy as well, in the brain. And so mitochondrial health is so important for mental health, because of energy, but because of all these other reasons as well. Um, and lactic acid is super interesting too. That there's now, I think, a lot of data showing that lactic acid improves brain health. And so, of course, when we're exercising, we use it as a measure of how healthy our mitochondria are. But if we exceed our lactic acid threshold and make lactic acid frequently, that's going to improve brain health. That's directly correlated to increasing BDNF, and
Hmm.
that's one of the mechanisms. And
Right.
so
So
we want to exercise and make some lactic acid some of the time, and some of the time go exercise right at the threshold as well.
right, vigorous exercise, good for BDNF.
Yeah,
Okay. The thing that I love about this study
yeah,
is the MRS data, because
Yes.
I think this really shows, what types of the brain are actually impacted. Like the anterior cingulate cortex had an 11.6 decrease, um, with there's a decrease in glutamate and glutamine,
Yeah.
right?
Yeah. I think it was 13% in the combination of glutamine and glutamate, I believe. Um, and that's really significant. That's big
Yeah.
because, first of all, we know that glutamine and glutamate get lowered in anticonvulsant treatment of bipolar disorder. So that this is a known mechanism by which things like valproic acid and lamotrigine help in bipolar disorder. This is the one of the mechanisms by which those anticonvulsant medications work. They lower brain glutamine and
These
glutamate.
these are excitatory neurotransmitters,
Exactly.
neuromodulators.
Yeah.
Um, One of the interesting things is that clozapine increases glutamate neurotransmission,
Hmm.
um, which I'm not quite sure how it relates to this area specifically having decreased, because I
Right.
think you have sometimes different things going on, but clozapine indirectly improves NMDA glutamate receptors. It blocks 5-HT2A receptors, which inhibits glutamate release. So, indirectly boosting glutamate release in the prefrontal cortex. Okay, so maybe
Okay.
that's where it is.
Different area.
So,
Yeah.
so if we're boosting in the prefrontal cortex, that maybe has a different impact than in this study when we're seeing it in the anterior cingulate cortex decrease.
Right.
Okay, so that makes sense to me. Is um, because in the anterior cingulate cortex you have emotional regulation, you know, you have cognitive control. So having maybe a blunted there, we have some increased emotional regulation, right?
Right. Right.
Um, Maybe
Yeah. I
less
mean,
rumination, less like heightened emotional processing. Go ahead.
yeah. It sort of makes me think about this question that is still puzzling me, so we know that antipsychotic medications are obviously really helpful for psychosis. That they're doing something very different to metabolism than what ketogenic diets are, which are also we're now seeing are helpful for psychosis. So how do we explain that? How do we explain why antipsychotics, even though they're harming metabolism, why are they helping with positive symptoms of psychosis, especially in these acute settings, which we know that they do. I mean, clearly they do. And we just don't know the answer to that question. I've asked it to Chris Palmer, and his answer was interesting. He says that when the neuron's running out of energy, it can either get hyperexcitable or hypoexcitable. It can either start doing too much or get hypoactive, and that when we replace the energy or fix the energy in the neuron, it's now going to do its job the way it's supposed to. It's not going to become hyperexcitable or hypoactive. And so, it has the ability to sort of get the neurons to do what they're supposed to be doing in different regions. And so it's not like, we're just, turning something on or turning something off. Medications are kind of blunt in that way. They're just doing one thing. Whereas this has many mechanisms of action that have been shown in the epilepsy literature. And we just don't know yet in mental health all these mechanisms, but we're seeing a nice suggestion here about lowering glutamine and glutamate in the anterior cingulate cortex in bipolar.
Yeah, and I think that's a good point. It's like, what is the mechanism? We're not sure. Also in the study, they showed there was a decrease in total choline in the anterior cingulate cortex and the posterior cingulate cortex.
Yep. And this
Um,
other one, myoinositol as well, which is a secondary
mhm.
signaling molecule. I don't know if you know, some people take myoinositol as a supplement for various things. It seems to help with severe OCD and anxiety. There's some very small studies looking at that, but I do know a lot of people who take that supplement actually.
There was no significant metabolic change in the right dorsolateral prefrontal cortex, which is interesting.
Yeah.
But we're looking at a, we're just scratching the surface here. I think was what you're saying as well. It's like, and when we look at diet studies and you look at big changes like this, it's not just one upregulation of one protein.
Right.
It's there's probably 10,000 things going on.
Exactly.
Which one of those is the thing that's going to make the biggest impact for the patient? We're not sure. Just like in exercise, there's tons of things going on.
Exactly. Exactly right. Yeah, we're doing something that has such a profound effect on physiology that it's going to be hard to find exactly what the one thing is, and that's what they found doing all this research on ketogenic diets and epilepsy. That they've come up with about 7 or 8 different mechanisms that various researchers think are really important, and the most important one no one can figure out what the one mechanism is for which it works so well in epilepsy. And I think it's going to end up being the same. And therefore you can't create a pill that's going to do what exercise does or what a
Right.
ketogenic diet does for the brain. We'll
Yep.
never have a pill.
Yep.
Yeah,
You can't just probably take like the bulletproof coffee type of thing, like that's probably not going to be enough because you're and just okay, I'm going to take this supplement and then
right.
go on eating a lot of highly processed foods and
That's right.
foods that
You
are
won't, you won't have as
pro-inflammatory.
good of an effect. Although interestingly, they've done these studies on MCT oil that are fascinating. People with mild cognitive impairment, they do a mini mental status exam on them, and then they give them MCT oil in a fasted state, and then they do a mini mental status exam on them an hour later, and they get significant improvement
Hmm.
just from one dose of MCT oil. Um, just because they made some ketones, and for those folks, this mechanism of brain insulin resistance is probably a really important one, and that immediately gets bypassed by making some ketones because
Hmm.
ketones don't need insulin to get
Yeah.
into neurons, whereas glucose does need an insulin signal to get into neurons, and so you bypass that blockade right away, and you get an immediate boost and an immediate benefit. But I totally agree with you that that's not enough for most people to have a profound, you know, lasting mental health change. Just doing some MCT oil is not gonna do it.
Yeah. And I think the other thing that I've been thinking about with this is like, I'm not just, I'm not going to only do this with patients, right? This isn't the only treatment I'm thinking of.
Right.
Exercise as well. And
Oh yeah,
some of the,
yeah. I love to
other things.
combine all these various important lifestyle things. So, ketogenic diet, or even a low-level ketogenic diet, or even just this low glycemic index diet, if that's all someone will do. Just a clean, healthy diet that doesn't have sugar and processed flour, and will make a little bit of ketones. Exercise, especially if we can get them to do some resistance training and some high intensity work as well. Mindfulness training, and then some circadian rhythm work as well is super powerful for a lot of
Hmm.
our folks. Um, and I talk about that, kind of all day long. Sometimes I feel like the importance of getting out and seeing morning sunlight and blocking blue light at night and getting outdoors during the day, eating meals at regular times, waking up at regular times. That is incredibly powerful for mental health and physical health. And it's so against the grain of what most people are doing that you can get huge benefits just from making these small interventions.
Hmm. Yeah. I think we should kind of get into the practical stuff as much
Yeah,
as possible at this point.
sure.
So when someone is getting into ketosis, what are some things that you think they should know? Like, let's say someone's listening to this and they're like, okay, I'm going to try this,
Right.
or I'm going to get my son on the ketogenic diet. Like, what are the things that they should consider in that process?
Yeah. Well, first of all, a couple of, absolute contraindications. You can't do a ketogenic diet if you're taking an SGLT1 inhibitor or SGLT2 inhibitor, these drugs that are used for diabetes. So, most people are not on those medications, but that happens to be an absolute contraindication. You can get ketoacidosis from that.
Hmm.
Otherwise, there's very few absolute contraindications. If someone's really severely underweight, I wouldn't do it. Um, it is done quite often clinically with people with restrictive eating disorders. We could go into that a little bit, but and that might shock people. It sort of shocked me when I first heard about trying this in someone with a restrictive eating disorder. So the things to know are start gradually. It's not a great idea unless you're really under, a team of professional care to do this all at once. So I generally like people to start with cleaning up your diet, get rid of sugar, try to get rid of some processed flour. Do that for a couple weeks. Keep eating veggies. Um, I like people eating animal protein, but make sure you're getting adequate protein all the time. Those are really important factors. And then just start gradually reducing carbohydrates. So maybe start with one ketogenic meal that has very low carbohydrate for a
Mm.
week. And then then in the second week, maybe add in a second meal of the day with very low carbohydrates. And then, by the third or fourth week, you can do all three meals. And when you're getting rid of all these carbohydrates, so when I'm, just practically speaking, bread, rice, potatoes, we just aren't sugar. We're not eating any of that. Unless you're getting a really, well-made ketogenic version of bread, which can be done, but it's not easy. We have to replace those calories with healthy fat calories. So what do we mean by healthy fat calories? So there is some controversy in this world. I won't get too much into the weeds, but everyone agrees that monounsaturated fats are healthy. There's really no controversy about monounsaturated fats. So
Yeah.
high in things like olive oil, extra virgin olive oil, avocados, avocado oil, nuts, and seeds, in their whole form, not seed oils, but whole seeds, and maybe minimally processed seeds like tahini is like ground sesame seeds, for example. Um, so generally higher in monounsaturated fats in those foods, all very safe to eat. Um, and then, animal fats, some amount of animal fats are probably healthy and important. They have more saturated fat. They still have the other fats in them as well. But if they're well cared for animals, there may be some benefits to that. Higher omega-3s in grass-fed beef versus not, and grass-fed dairy also has higher in omega-3s. Dairy is one of the ways that sometimes people get more of their fats in a ketogenic diet. It tends to be easier and more satisfying if someone tolerates dairy and is willing to eat cheese and
Mm.
cream and things like that. And it often makes things taste delicious. So, for people who do well with dairy, that's a good trick. Um, and then, I do generally advise people to avoid a lot of seed oils because they're highly processed and they oxidize very easily. So saturated fats are more stable than these polyunsaturated fats. Um, so replacing with healthy fats, and because you're going to be eating more fats, you got to pay attention to
The
your fat
quality.
your
Yeah.
fat content. Yeah,
Olive oil, love it. Okay,
yeah,
so here's my thought. Dark
yeah,
chocolate. Okay.
yeah,
So 80%. How much of that can I eat?
yeah. Yeah. Well, okay, so I like chocolate too, by the way, and I've found that you can get chocolate that's made with a sweetener called allulose.
Allulose. Okay.
It's new sweetener that most people are these heavy duty scientists are now agreeing is probably the best of the artificial sweeteners of them all. Um,
Really?
Allulose is a naturally occurring sugar similar to fructose that exists in foods like tapioca and corn at very low quantities. So they just purify it out of these other, vegetables, and then you can get it in powdered form. It tastes almost exactly like sugar,
Mm.
but our body doesn't metabolize it, so it ends up being no calories, and it tastes sweet. And it doesn't seem to raise insulin or blood glucose at all. Some of the other artificial sweeteners actually raise insulin levels, and that's problematic because the only way we make ketones is to lower insulin levels. So allulose doesn't seem to do that, and it actually seems to have some GLP-1 activity, which is also fascinating.
Mm.
So some people take high doses of allulose instead of a GLP-1 inhibitor if they can't afford it.
Wow. Interesting. Okay.
Yeah, interesting.
Okay. So
Anyway, so,
allulose.
so, so you can get chocolate made with allulose or stevia, or
Okay.
just the highest percentage cacao that you can. So there's very little sugar in it.
Hmm.
So I mean, there's one company that makes like 95% cacao.
Oh,
You
no,
know,
yeah, there's 100%. It's just
100%. I mean,
unpalatable.
100%. Yeah, 100% is maybe not
Absolutely awful.
palatable, but 95% from a good company that really knows what they're doing can be
Okay.
really delicious, I think.
Okay. Okay.
Yeah.
Nice. Okay.
Yeah.
Okay. What's the hardest? what's the hardest thing that you find most patients?
Yeah, before I get to that, the one other the caveat to say to people is if they are going fast into ketosis, they have to really pay attention to drinking tons of fluids and taking electrolytes, because you have this diuresis when you first transition into ketosis that can be, really uncomfortable. There's this idea of keto flu. Some people
Hmm.
try this on their own and they say, "Oh, I hate the way I felt because they went really fast. They didn't replace their electrolytes. They got headaches and low energy and low blood sugar, and they felt terrible." So that's why I
Yeah.
advocate a slower approach. It's much more likely to feel good. Some amount of measuring ketones is a really good idea. We mentioned blood measurements with a device. There's also breath devices that are pretty accurate now. And so if someone really
Hmm.
doesn't want to prick their finger, they can get a breath meter.
Hmm.
And I found that, if someone's not shooting for, a real, we're not trying to be super accurate about their ketone levels. They're just more casual about it. That's another approach that we can take. Just use the breath meter.
Okay, so with the electrolyte supplementation,
Yeah.
um, common question like how much, what do they do? Like what's your take on that? Like 3 to 5 grams of
Yeah.
salt?
So you could just use sodium if you and that generally can work. We're also losing potassium and magnesium as well.
Yep.
So ideally we'd replete those too. There is a salt that's made that's half sodium, half potassium. That's an interesting product that you could use in the beginning and just really because now you're making your own food. You're not eating these processed foods, right?
Hmm.
You have to really salt your food. And then additionally, you might put some of these electrolytes in your water bottle, once or twice a day in the first couple of weeks.
Hmm.
And make sure, and like I said, just drink lots and lots of water, 6, 8 liters of water for sure, and maybe
Mm.
more. Yeah.
Wow. Okay.
Yeah. If you're going fast, especially because there's this big diuresis that happens when you go into ketosis and it takes away a lot of your electrolytes and water and you can get, really dehydrated otherwise. Yeah.
Okay. I'm gonna have to watch that because I do sauna as well.
Yes.
I'll lose 4 or 5 pounds in the sauna.
Me too. Yeah, yeah, I do that as well. You should definitely be taking in lots of electrolytes and really pound the water. Yeah, if you're gonna do ketosis and sauna at the same time, especially, yeah, you really got to be careful
Yeah.
and make
Okay.
sure to get some magnesium because you're losing all these electrolytes.
Magnesium, potassium. Do you do potassium pills ever, or do you tend to do the salt,
I
the salt
generally get
mixture?
these like little electrolyte packets.
Okay.
There's a couple companies that make them without any sugar at all.
Yep.
And they taste good, and they're just really easy, and you get a nice blend of those three electrolytes. I also, for some people, it's not a bad idea to take some trace minerals in the early stage as well. You can get a trace mineral supplement because you're losing all these electrolytes too. Especially if you sauna a lot, I would recommend a trace mineral supplement,
Hmm.
um, because you lose all these important things, zinc and selenium and iodine. It's all coming out in your sweat as well as toxins. But sweat brings out everything. Yeah.
Hmm.
Yeah. I sweat a lot, so I think about this.
I I think I need a sweat mentor here. I need you to send me your mineral recommendations.
Yeah.
Um,
But they can just get a little pill that has all these trace minerals in it, and then you just get the bigger quantity minerals in an electrolyte packet. It's pretty simple. Yeah.
yeah. Yeah, that's good. Okay. Any other practical recommendations that you normally tell people?
Um, let's see. I mean, I probably not the best time to like if you're really, especially if you're going fast and it's not the best time to try to get your personal bests in your exercise routine. If you're really into exercise, you're not going to want to push yourself to the max in the first couple
Mm.
of weeks. Your body is adapting to a whole new way of producing energy, and it's working hard to do that. You're turning on genes that have basically been turned off. We all have the genes to do this, but these genes are our survival genes that exist because we needed to survive in food scarce environments our entire evolutionary history.
Hmm.
But all those genes have been essentially, quieted down through epigenetics, through our diet and lifestyle.
Mm.
So we have to turn all these genes back on, and it takes some weeks to adapt to that. So I wouldn't, go for personal bests in your, in your training in the first few weeks. And then even after that, it may take some time to get back to, especially in endurance, if you're trying to train in ketosis. It's really great in the end for endurance. A lot of endurance athletes are ketogenic. It's, because you're essentially teaching your mitochondria to burn fat better. And so, beta oxidation is improved over time in
Hmm.
ketosis,
Yep.
but definitely not in the beginning. There's some adaptation that happens.
Yeah. I've heard about people training in ketosis and then competing with some sugar.
Yeah,
So it's
yeah.
like they've taught their body to mostly do ketosis and
But you
then
don't need that much sugar. Actually, the recent study came out that people who are these ketogenic athletes, they only needed to add back, I think it was like 7 grams of sugar per hour in these long
Hmm.
distance endurance things
Wow.
to get all the benefits
Interesting.
of having some glucose around. So we don't need to add that much, and our body's making glucose all the time. That's another really important point for people to know. Our brain is you know, additionally using ketones as fuel, but we never stop using glucose as fuel in our brains and everywhere throughout our body. Even if we're in the deepest ketosis and we eat zero carbohydrates, our body's making glucose through gluconeogenesis all the time and using it all the time. But we're
Hmm.
just making the amount that we need instead of this excess that we need to store as fat.
Really good.
Yeah.
Okay, we're kind of coming to a close here. Any final things you wanted to kind of bring out before we wrap things up?
Yeah. I mean, just trying to put it all together a little bit. We looked at the Wondering study about dose reductions of antipsychotics having better rates of full recovery than people who didn't do a dose reduction. We know about all the metabolic problems with a lot of these antipsychotics and mood stabilizing medications. And just thinking about the long-term health of people with severe mental illness. It's just, we know that people with severe mental illness die younger, on average, about 15 to 20 years younger than people without it. There's many causes of that, but metabolism is a big cause of it. And I think unfortunately the medications are a big cause of that.
Hmm.
So, thinking about people's long-term future, we want to think about this as, how do we heal and get to people to recovery long term? I think this really could have a role for a lot of people out there. And I don't want to happen what's happened in epilepsy and in diabetes, where there's been great randomized controlled long-term trials showing that ketogenic diets work, but doctors don't even mention them to people until maybe never, or maybe like 5 or 10 years into their illness, when people should be given an option. I mean, I just really believe that even if you don't, want everyone to do this, or you don't want to do it yourself with your patients, I think people deserve to know about this treatment.
Yeah. I think through this process of looking at these papers with you and kind of rethinking through this, it's like what I think I would like to do is I'd like to find a nutritionist in the different states that I'm licensed in, Florida, Texas, California, um, and someone I can trust, that I can kind of have like a partner in with some of these patients because it's almost like, you know, I need someone that can kind of hold someone's hand or the family's hand. I need to
Yeah.
find that person.
Yeah, I
Um,
have a suggestion for you. There's a practice that's nationwide of ketogenic dietitians, registered dietitians who all have experience with ketogenic
okay,
diets. And now half their
cool,
practice is mental health, actually. Yeah.
great. What's the name of it?
It's Advanced Ketogenic Therapies, run by Denise Potter,
Oh,
who's
okay,
who's been doing these diets for
yeah,
more than 20 years with people with epilepsy, but in recent years is really
yeah.
getting into the mental health space, and she has wonderful programs online for people. Yeah.
And then I also think your program is a great option. I'll just plug that at the end there. Just is a place to send people. I think there are people that are a good fit for that who are willing to go and travel and learn the ketogenic diet. And so I think that that is a really cool resource. It's called Accord.
Yeah, Accord. Yeah, and it's really helpful because there are some people and some families that, even with dietitian support, can't seem to get into ketosis at home.
Right.
It's hard, and
Yep.
think they're doing everything right, but they come to us and we just immerse them in it. We've got a chef and a dietitian, delicious food, exercise, mindfulness, circadian rhythms. People get, this huge benefit in a month or two, and then they're really excited to keep doing this when they get home. So it's sort of like an immersive jumpstart for people.
Yeah. Cool. And then yeah, I think the final thing is I'm going to be following these randomized trials, and
Yeah,
maybe we'll have you, maybe we'll have Chris Palmer come back on.
yeah,
Maybe we could when one of these studies comes out, we could you and me could interview the person that did the study. We could have them on together and
that
talk
would be
about
great.
their specific study and kind of just continue to educate ourselves. Um, but thank you so much, Matt Bernstein, for coming on. It's been a pleasure. I think you have a lot of practical knowledge. You're obviously, someone who's balanced, a psychiatrist who's been practicing for a long time. And that's the kind of person I like to have come on to kind of just give your wisdom and your experience. And this is just an added sort of uh, thing that we could think about with each of our patients. Like, is this right for them? Give them, mention it, look at the studies ourselves, educate ourselves, try the diet ourselves, so we can learn about it, and don't make the same mistake I made the first time I did it. I, I did not take enough electrolytes in. You lose like 6-10 pounds the first couple weeks,
Yeah,
and then
that's not
I continued lifting.
right.
I do powerlifting, and I would have these horrible spasms after. And my friend Darcy Tranquil, shout out to her. She was into the ketogenic diet for mental health issues a decade ago.
Oh, wow.
Um, she was all about it, and called her up, and she said, "Yeah, you need to drink a good liter of bone broth a couple times a day, and you'll be fine." And so, a lot of electrolytes in bone broth, right?
Yes, yeah. Well, yeah, I really appreciate you having me and being able to talk about this topic I'm so passionate about. And it was great to go through it all with you. Yeah, thanks.
Cool. So we'll have on our website, psychiatrypodcast.com, tied to this episode, we'll have all of your contact information. We'll have all of the articles that we talked about today. This is free. It's not behind a paywall. So please, you can download the PDF. You can share it with people. You can share it with your patients. We're just trying to give information out for free across the world. I know people access these kind of things and they find it very helpful. And so, if this is something you want to dive into deeper, please go there. There's more actually there than we had time to discuss. We've probably discussed about 30 to 40% of what we have on that document. So there's a lot more to dig into. And I'm going to be editing the next couple weeks, looking at each thing. And we talk about different groups of people that in particular may be of advantageous benefit to this from this diet. So yeah, we'll leave it there for today.